Good evening, everyone. Sorry for the delay. We'll quickly start off with our cases. We have 11 cases, 10 new cases, and 1 follow-up. The first 6 cases will be from Rainbow, and we'll start off with the first case. If Dashath is there, he can present the case.
Good evening, sir. It's a 3-month-old male child born to non-conformist couple who had failure to thrive and developmental delay, motor more than cognitive, and child also had a left eye optic disc coloboma and atrial septal defect, very small, not causing any congestive heart failure, facial dysmorphism, and bitemporal fullness was there, micronathia is there. And child also had a bilateral adducted thumb and spasticity in both upper limbs and lower limbs, but DTR were absent. Like lower limbs and upper limbs were tight, DTR were absent.
Okay. Yeah, so we'll go ahead with the images.
Yes, sir.
Here we have the MR images at the age of 3 months, and we have the axial T2s, flares, and T1 mediate sequences, and you can appreciate that the cerebellum is abnormal. It is dysplastic and has multiple microcystic foci in the bilateral cerebral hemispheres, predominantly in the subcortical subpiral regions. The brainstem is also abnormal. We'll have a look at that on the axial images, but you can see that it is not demonstrating normal morphology. So the posterior fossa features have cerebellar dysplasia, abnormal brainstem, and cerebellar cysts. Coming to the supratentorial brain, if you see the posterior, you just have a look at the sagittal image of the brainstem. It has this typical kinked appearance or a Z-shaped appearance. The tectum is hypertrophied or enlarged. Cerebellum or vermis is dysplastic, and you have this bilateral ventriculomegaly with a interhemispheric cyst communicating with the right lateral ventricle. The cyst is iso-intense to the CSF on all sequences. And if you come down to the T1 weighted thin cut sequences, you can appreciate that the cortex is malformed. There is polymicrogyria in the bilateral frontal and parietal regions, also some areas of the perisylvian region. Again, the cyst can see is communicating with the lateral ventricle. So features of posterior fossa malformation with cerebellar cyst, kinked brainstem, interhemispheric cyst communicating with the lateral ventricle, and bilateral polymicrogyria pattern. If you have an approach, this is just a rough diagram which I tend to follow. If you have the brainstem, if you concentrate on the brainstem, if it is kinked or Z shape and has cortical malformations, if there is a dysmorphic basal ganglia, one must suspect turbinopathies. If there is the basal ganglia is normal, as seen in our case, one must think of alpha dystroglycanopathies. Again, cerebellum, this is not conclusive, but this is just a rough approach. If there is dysplasia and presence of cysts, with presence of cortical malformations, if it is cobblestone, one must think of GPR56 or the new gene that it is ADGRG1. If there is polymicrogyria, one must think of alpha dystroglycanopathies. The interhemispheric cysts can be subdivided into type 1 and type 2. Type 1 is again subclassified into type 1A, B, C. Our image demonstrates the type 1A pattern, which is iso-intense to CSF, urinocular, and communicates with the ventricles. Follow-up, Dashrath, I think the CPK was elevated.
Yes.
Any other lab diagnosis or?
We suspected on seeing image neuroimaging the alpha dystroglycanopathy and sent CPK levels.
Okay.
CPK.
We are internal.
Just the thing point was we know the findings of catastrophes. As seen in our case, have supratentorial malformations and also infratentorial changes.
Left.
Again, cerebellar dysplasias with cysts.
Perianal abscess.
We have alpha dystroglycanopathy as one of the primary differential.
Actually, this child was referred for hydrocephalus surgery.
Yeah.
CT scan was done and referred for hydrocephalus surgery, and surgeons had seen it and were considering whether it needs to be done. But the head circumference was within the centers, but the child had failure to thrive. So that's when we evaluated the multiple other abnormalities clinically. We thought that it's obviously not a condition where a surgery would make benefit. So then we entered the MRI for further delineation, and the diagnosis of alpha-dystrofik neuropathy is very likely. And instead, genetics have been set.
Okay. At this point, I'll open the case. Aigen and any other panelists have any further comments?
I think it's very classical situation in terms of, as it was said, in the broad field of congenital muscular dystrophy, Walker-Warburg type, yeah,
Okay.
autosomal recessive inheritance.
All right. Okay. Thank you.
Well, just one.
Yeah.
Can you go back to the table? I mean, adducted thumb is just a very specific.
Yeah.
हाँ पता नहीं वो डब्बा देखना पड़ेगा घर पे हाँ होगा यार डब्बा देखना पड़ेगा घर पे खाना
Can I add one more sentence? Some
Yes.
genetics call this adducted thumb also cerebral thumb. So any prenatal nature can go along with adducted thumb.
Okay. Right. Thanks, Aigen. We'll move on to our next case. This is a 2-year female child with global developmental delay, central hypotonia, neonatal encephalopathy with metabolic crisis, and had fever-triggered seizures. The scan is done at the age of 2 years. So we have the MR images, that is the T1 sagittal image, and you can appreciate that there is a pattern of pontocerebellar hypoplasia. The brainstem is hypoplastic, and also the pons is, in comparison to the midbrain and the medulla hypoplastic, are reduced in height. The vermis is also hypoplastic. There is reduction in the volume of the corpus callosum, generalized atrophy of the white matter and the parenchyma of the supratentorial brain parenchyma, as you can appreciate on the T2 axial sequences. I cannot appreciate any malformations per se, and no signal changes other than the atrophic brain. The finding, I would say, is non-specific. Some clinical clues and imaging clues can further help in narrowing the diagnosis. This is a review paper authored by Aigen, but I think, at least on the imaging, I can say that this is a neurodegenerative disorder with a pontocerebellar hypoplasia pattern and possible genetic diagnosis. At this moment, I'll open the case for further comments.
Can I come back? What does it? What is the meaning of metabolic crisis? What was abnormal? Was lactate elevated?
I don't think we have Dr. Ramesh on the panel.
I'm just
Sure,
asking.
Yes.
ECH6 goes along with elevated lactate very often.
Yes, yes. Okay. Since we don't have further information, we'll probably get back with genetics if it is done. Case 3, Dashrath.
The motor more than cognitive. And central hypotonia. He also had a cerebral vision impairment, and aplasia cutis initially found at birth, which got healed by the day of life. Child has disorders like inverted nipples, broad depressed nasal root, upturned stubby nose. We suspected some structural malformation, view of static and dysmorphic.
Coming to the images, on top we have the flare axial images. The supratentorial brain parenchyma for an 8-month-old is normal. Deep brain nuclei are normal, but the doubt was in the posterior fossa. This hyperintensity centered in the left cerebellar white matter. You have this ill-defined or well-defined focal hyperintensity of the cerebellum and also extending up to the peduncles. You can appreciate that on the T2 coronal and sagittal images. No corresponding restricted diffusion. No, it is slightly iso to hypointense on T1 weighted non-contrast sequences, and there was no blooming on the SWI sequences. It is a pretty non-specific finding on imaging. I would think of the bright objects or the foci of altered signal intensity or a hematoma. Spectroscopy, I think, wasn't done. So the differentials are possible altered foci of high altered signal intensity and hematoma and possible low-grade glioma, but I think further sequencing and characterization needs to be done for this for the abnormality over here. Any neurocutaneous markers, abnormalities, Dr.?
No neurocutaneous markers.
Posterior fossa signs, ataxia, anything like?
No, sir.
Okay. At this moment, I'll open the case for further discussion.
I have no contribution.
It was an incidental finding. It was seen on CT as well as hypointensity. To further characterize, we had got this MRI done. It looks very likely hematoma is what we thought after discussion. Child is not symptomatic for this lesion clinically.
Okay. Will we have a follow-up, Dr. Lokesh, maybe in 6 months?
Yeah, that's what we have suggested the family. We'll have a follow-up. And we did sometimes these children can present with epilepsy, cerebellar gangliogliomas, hematomas. So, but EEG might be normal actually, unless you do an invasive EEG in this situation. Thank you.
Okay, good. Thank you. Moving on to the next case, Dashrath again.
Yes. It's a 3-month-old female child, sir, born to non-consummate parents, presented with a cluster of focal clonic seizures over a 3-day period, which was preceded with gastroenteritis. After starting of these focal seizures, child had a decreased interactiveness, no visual fixation, and no focal motor deficits. So VBC at admission was no metabolic acidosis. HP was 8.5 gram per deciliter and CRP 6 mg per deciliter. Outside, before coming here in the outside hospital, CSF was done on day 2 of illness, which was normal. Here we have repeated CSF analysis. It was traumatic, which was showing 80 cells, 90% lymphocytes. Viral PCR was borderline positive for HHV6. So initially we thought of seeing imaging, neuroimaging and clinical picture, viral encephalitis as the first possibility.
Okay. We'll have a look at the images and then get back to the thiamine levels. So here we have the axial diffusion and ADC sequences from the films. And you can appreciate that there are confluent restricted diffusion in the bilateral cerebral hemispheres, predominantly involving the subcortical regions and also the deep white matter. The corpus callosum is also involved in the region of the splenium of the corpus callosum. Some areas of the cortex are also involved in the bilateral, parietal, and occipital regions. The deep brain nuclei are spared. The lesions do not appear to be conformed to a vascular territory. On the T2 and phase, it is the corresponding areas on the diffusion are hyperintense on the T2 weighted sequences. So based on that, we initially thought of a possibility of viral encephalitis or infection-related changes. Then a possibility of thiamine-related or thiamine deficiency was raised, and this was an image or case from a paper published by us, I think last year. And you can see that the confluent areas of restricted diffusion are seen in one of the cases, which was published. Another differentials which was less likely but to be considered was the acute leukoencephalopathy reduced diffusion. that can be a triggering process of an infection virus or a toxic cause can cause these changes. So the differential we thought of are viral infection, thiamine-related deficiency disorders, and a relatively less likely ALE-RD pattern. And at this moment, I'll open the case for further discussion.
So at the time of admission also, as the clinical picture is neurological deterioration after a mild viral infection in the form of gastroenteritis, we thought of metabolic disease also. So empirically, we started thiamine and biotin on day of admission. And over the next 2 days, child's attention towards mother and social smile was regained, was able to breastfeed by the end of second day of admission. And we could able to discharge on day 3 of admission, and follow up on a phone call. As per parents, child was to baseline sensorium right now, which is less likely with viral encephalitis with that neuroimaging.
Okay.
So most likely it is thiamine deficiency. So even mother thiamine levels we sent, which came low.
Dr. Nihaal, any specific handles, because it is very non-specific pattern from the MRI. Any handles?
Usually thiamine-related periaqueductal region is more commonly involved.
Yeah.
But I think in the infantile age group, which we have seen in our case series, the pattern is slightly different than what it's seen in the early childhood, where they are basically having their periaqueductal regions and also involvement of the mammillary bodies. These changes, which we have seen in 2 of our cases in this case series, but these are again, I think neonatal or early infantile period group. So cortex and subcortical involvement is one pattern of thiamine-related deficiency disorders, but more specific handles are the periaqueductal region and mammillary body involvement.
Yeah, these are the sort of acquired thiamine deficiency, not the thiamine biotin responsive syndromes.
Yeah.
Okay. Thank you. That's helpful.
Okay, if there are no further comments, we'll move on to the next case. Case twice from Dr. Rashmi. Dr. Rashmi, would you like to present the case?
Yeah, so this is a 2-year, 10-month-old child whom I've been following up since the baby is 2 months old. There was one of a twin. The other twin is extremely well. So they were preterm, 36 weeks, low birth weight, and small for gestational age. And it was IVF conception. So when the baby was born, I think the concerns were more around micropenis and bilateral undescended testes. And initially they suspected hypogonadotrophic hypogonadism. But following on, they had an MRI brain at 2 months. I don't know if they shared with you, Dr. Nihaal, the 2 months MRI brain.
Yeah.
You have it, okay. So then they had said that there was some cyst or something in that MRI brain, and some sort of a genetic problem was suspected. So that time the exome sequencing was sent by the endocrinologist. So I don't think we gave, and we said that there's a little bit of MRI changes, but beyond that, we did not give them too much information when looking for genetics. So the baby has mild global developmental delay and problems with visuomotor coordination, but he's able to walk and run and all of that. And initially he had status epilepticus, I think at the age of 6 or 7 months. He was on levetiracetam, well controlled. And more recently, he has developed seizures and repeated his EEG last month, which showed temporo-occipital spikes. And we have just started him on oxcarbazepine. I don't think he's had further seizures since starting oxcarbazepine. And this microdeletion for Prader-Willi and clinical exome sequencing, as I said, were sent by the endocrinologist initially. He's had the operation for the undescended testes.
Okay.
So I think that's the thing. And at the age of 2 months, when his MRI scans, they took it to NIMHANS as well. And that time they had said about tubulinopathies in the NIMHANS report. But we did not take it that much seriously. So we repeated an MRI recently after he had the second bout of seizures, which I think Dr. Nihaal will show us.
Yeah, sure. Thank you. So here's the first set of MRIs at the age of 2.5 months. And you can appreciate that there is some areas of simplified aeration, not very severe, but mild degree in the parietal, frontal, and parietal regions. The cingulate cortex is also slightly dysgeric. But when we come to the ventricles, they are slightly prominent, asymmetrically prominent, and also dysmorphic. This is likely owing to the underlying abnormality of the basal ganglia. The basal ganglia are thickened, dysmorphic. You can see that the right and left basal ganglia have different morphology. Better appreciated also on the coronal images. You can see that the basal ganglia are not symmetrical in morphology. There is abnormal. The frontal horns are also dysplastic. No abnormalities in the posterior fossa. The corpus callosum is also slightly hypogenetic. It is slightly foreshortened but almost complete. To the follow-up scan at 2 years, 9 months. Again, similar changes in the anterior cingulate cortex, and you can appreciate the midline structures, the deep midline structures. The basal ganglia again dysmorphic, abnormal appearance of the bilateral lateral ventricles. No changes in the posterior fossa. Cerebellum is normal. Brainstem appears to be normal. Again, on the T1 axial images, you can appreciate the abnormalities of the basal ganglia and also the anterior cingulate cortex. And coming down slightly lower to the posterior pericilium region, you can appreciate that the cortex over here is slightly thickened in comparison to the contralateral side. Again, the corpus callosum is almost completely formed, but it is foreshortened and hypogenetic. There is probably mild brainstem hypoplasia, but the pontine belly is relatively well preserved. And in the coronal image on the hippocampi, the left hippocampus is slightly atrophied in comparison to the right. So based on those changes, we had suggested the possibility of tubulinopathy based on the imaging abnormalities of the basal ganglia, resulting in abnormal dysplastic frontal horns. They can have corpus callosum abnormalities. Posterior fossa abnormalities can present with asymmetrical appearance of the brainstem on the axial images, and they can also have some areas of cerebellar dysplasia. Other abnormalities can be present in the hippocampus and also the corticospinal tracts, and can also have cranial nerve hypoplasia. So these are just images from the literature, and if you see that the images are very similar to our case. Corpus callosum abnormality, they have this central pachygyric pattern and abnormal basal ganglia. So based on the imaging, we had suggested the possibility of tubulinopathy, and I think Dr. Rashmi is further assessing for the clinical exome or the whole exome sequences. But I'm not aware of the syndromic association or the systemic findings with the tubulinopathy. So at this point, I'll open the case.
Yeah, because there's so many other systems are involved. No, I was thinking of asking you to reanalyze the clinical exome, so, given these new findings, and then if that doesn't, we don't get any answers with that, then we can think about whole exome, repeating the whole exome again. That's what I was thinking of doing. This tubulin genes, no, are they intronic? If they're intronic genes, they may be difficult to detect on both whole exome and on clinical exome, right?
Yes. The diagnostic yield of tubulinopathies is not 100%. Yeah. And I think
that's what
Nihaal, the constellation here is absolutely suggestive of tubulinopathy. There was a paper a few years ago just in terms of mnemotechnic title, Dysmorphic Basal Ganglia, Think Tubulinopathy.
Yeah, no, I agree. I was looking into it. I saw that some of the genes were, if they're intronic genes, then they're not detected by whole exome also. You'll have to do genome sequencing to detect them. I don't think we have any specific treatment for this, no? There's no, because it's just it's more like a genetic malformation rather than anything else.
Yes, I'm not aware of the treatment, but it's a genetic malformation. Again, would you screen the twin child? Is it? Do we need to screen
the twin child is absolutely fine. Apparently, developmentally completely normal, no problems at all. It's dichorionic twins, so they are different, completely different egg and sperm. No, so the twin is absolutely fine. So I have not met the twin, but that's what parents told me when they came. Yeah, but that's very nice description, Dr. Nihaal. Thank you. I mean, the way you've described the basal ganglia deformity and all of that. No? It's nice. It makes sense now. Thank you for that.
All right. Thank you. Hope we get an answer on the sequencing.
Yeah.
All right, thanks. Case 6 is from Dr. Kavita. Sahil, if you're there, you can present the case.
Yes, sir. This is a 4-year, 10-month-old male child born of second issue of third-degree consanguineously married parents. He came with history of excessive tremulousness and a rash since 4 years of age, and since 10 months back. There was excessive tremulousness which was noted during some action, basically intentional tremor, and which was sudden in onset and non-progressive. And he had a rash which was more when he had macular type rash, which was more exposed to sunlight, and he had a mild global developmental delay, mostly motor, but now he had caught up. His developmental, his birth history was normal. So on examination, he showed signs of cerebellar signs, and also there was a malar rash which was present, and his weight and his height, which were less than third centile for his age. So we further investigated the child. We did a CBC which showed nothing, and in view of ataxia, we did a serum ceruloplasmin AFP levels, B12 levels, which was normal, and we came to a conclusion that probably looking at some genetic etiology syndromic variant here, probably the biotinidase deficiency, but the child did not have seizures or such. So we did an MRI as he was showing cerebellar signs,
Okay.
Yes, sir.
Yeah.
All right.
So we have a CT and MR. I think one done at the same time. I think 1 day gap. Yeah. So on the CT, I cannot appreciate any abnormality. In particular, I cannot appreciate any calcification in the deep brain nuclei. Yeah, so overall, a normal appearance of the supratentorial brain parenchyma, maybe slightly hypoplastic vermis, and slightly reduced volume of the brainstem, in particular the midbrain. But supratentorially normal, no calcification, no hemorrhage. We have the MR images, which is done a day later. I don't have the T2 weighted sequences, but on top is the diffusion weighted sequences. No areas of altered signal changes or restricted diffusion on the diffusion weighted sequences. On the FLAIR images, for a 4-year, 10-month child, we have these abnormal hyperintense changes in the bilateral cerebral hemispheres involving the periventricular and deep white matter. There's latent sparing of the corpus callosum. The posterior anterior limboventricular capsule also not very clearly delineated. Nothing on the SWS sequences, no mineralization. T1, the myelination appears to be normal, but on the FLAIR, you can appreciate that there is some degree of delayed myelination or a possible hypomyelinating pattern. No volume loss in the supra or infratentorial brain parenchyma. A slightly reduced volume of the brainstem, in particular the midbrain, and slightly mildly hypoplastic vermis. But other than that, I cannot appreciate any other findings. So probably going down the pathway of delayed myelination, hypomyelination. I think Sahil has a diagnosis. If you can give out the diagnosis, we can go for further discussion.
Yes, sir. So we had sent a clinical exome for this child, and it turned out to be cocaine type B syndrome. So the dilemma here was the child. There are two types basically, type 1 and type A and B. So it is said that B comes in a neonatal stage and it is very rampant, and by this time the child will have a full florid cocaine syndrome. So our child, we had done a NCV BERA which was normal, and his CT also did not show calcifications. Although it is said by 3 years there are 96% of individuals have calcifications. So we were just thinking on that line, what could explain it. The rest of the features like his height and weight are explainable. The skin rash is explainable, ataxia is explainable. But the MRI findings are going against it. Even his fundus is also normal. There are chorioretinitis and salt and pepper type of chorioretinitis features are very common in cocaine syndrome. So you were thinking of that aspect. So just yeah.
So is it a heterozygous or a homozygous mutation?
Sir, it's a homozygous mutation, sir.
Is it a missense splice site or terminal? Because missense mutation can...
Yes, I have not got the whole of the genetic report. I'll just let you know. Yeah, because just the today only the report has come. and I'll just tell as soon as it comes.
Because you can, not always that gene is causing the problem, even if it is a homozygous mutation, unless things match, because you may pick up things which are not important, even if they're homozygous.
Okay, sir.
That's what
Okay, I'll just call the.
especially, so if it is an intronic mutation, so you can, like Rashmi asked, can you pick up intronic on whole exome? One can, if it is splice site. So when the exome joins the intron, if you have a mutation there, then you can get an intronic mutation. So splice site mutation which terminates the gene, it's very important. That's going to be pathogenic. But if it is a missense mutation, you might not be sure.
Okay, intronic will not be picked up, sir, on clinical.
Yeah, intronic will be picked up if it is at the junction of the exome and the intron. So you call it splice site mutation. So that will be still intronic. It's very important.
Okay, sir.
So it doesn't. So exome can pick up intronic mutations at the junction.
Okay, okay, sir. Okay, I'll have the report and I'll get the report and see.
Can I come back to the rash? Can you explain again what type of rash is this? Is it sun sensitive?
Yes, sir. It is a photosensitive rash, mainly on the malar region of the face, and it is a macular type, sir. It was only on the face, sir. Nothing, nowhere else.
No organomegaly also, I think. No progeria type cases.
Yeah. No organomegaly, no cola-colored urine or recurrent pain in abdomen or anything.
But you say that the gene is pathogenic, or is it variant of concert?
Yes, sir. Yes, sir. They have sent me a photo of it. It is pathogenic. They have sent. I'll see what it is there. I'll see. It is given pathogenic. Yes, sir. Okay. Thank you, sir.
Okay. So are we taking it as pathogenic, or do we need to reevaluate anything on the clinical aspects which can help for further comments?
Sir, apart from the few clinical features, the MRI features and the ophthalmic features are not matching. MRI feature is not matching. So yes, it could be. We'll further evaluate it. So we'll search the literature again.
See, the photosensitivity, if there is a failure to thrive, and hypomyelination, some cerebellar atrophy are all features of a DNA repair disorder.
Yes, sir. DNA repair. Yeah. It comes in DNA. Yes, sir.
Yeah, so it will be part of that.
Okay.
Because the clinical profile is matching to, because we are still learning, because cocaine, if it is described before, we are picking up things because we are doing the genetics. So we are picking the milder forms which are not described. So especially if a lab says pathogenic, a good lab, there must be some very important reasons why they write it as pathogenic, because otherwise they report as VUS. And it does match, as Lokesh says, a DNA repair disorder.
Okay, sir. Okay. Okay, sir.
Okay, right. Thank you.
Thank you, sir. Thank you.
Next case is from PhD. If you are there, you can go ahead with the case. Okay, I think we don't have PP. I'll just go ahead with the case. So this is a 14-month child born of third-degree consanguinity. Was developmentally normal until the age of 11 months. At the age of 11 months, presented with fever, had multiple episodes of seizures and encephalopathy. Dengue serology was positive. Post this, the child has regressed completely, with also presented with severe dystonia, spasticity, feeding issues, and visual impairment. Over the last 2 months, the child is slowly showing improvement. I'm not sure what the medications are over the last 2 months, but we'll go ahead with the imaging. So slightly distorted images, but these are the images at the age of 11 months. And on the T2 axis, you can appreciate that there is confluent abnormalities in the bilateral cerebral white matter, periventricular region extending up to the subcortical white matter. The basal ganglia and thalami also demonstrate some degrees of hyperintensity, but predominantly in the thalami. Brainstem, I cannot appreciate any significant findings, and also in the cerebellum of the vermis. Flare images, again, predominantly hyperintense changes with areas of cystic degeneration or cavitation in the peripheral aspects. Diffusion, there was some area of restricted diffusion in the periventricular regions and also in the deep gray nuclei. This is a non-contrast T1 weighted sequence, and you can appreciate that there are T1 hyperintensities involved in the bilateral thalami, and also the corresponding white matter changes demonstrate hypointensities. I don't have an SWI sequence centered at the deep gray nuclei, but there are some areas of blooming in the abnormal white matter changes in the bilateral, frontal, and parietal regions. At this point, possible thinking of ANEC involving the deep gray and nuclei and the white matter, which can also the imaging findings can also be present in dengue related infections. But the dilemma was on the follow-up imaging. So this is at the age of 14 months. And at the age of 14 months, you can appreciate that the white matter changes are again remains relatively stable or slightly progressed. No diffusion changes in the white matter or the deep gray nuclei. There is a almost complete cavitation or cavitatory appearance of the involved white matter. Brainstem and cerebellum are relatively spared. There is some degree of volume loss in the bilateral thalami, and you can appreciate that thalami is slightly hypointense. I do not have a T1 weighted sequence, axial sequence, but on the sagittal images, you can appreciate that thalamus demonstrates T1 hyperintensities, probably residual hemosiderin or calcification over there. Again, on the sagittal images, you can appreciate the extensive white matter involvement, cavitatory white matter involved appearance. There is a reduction in the volume of the brainstem, and also the vermis is a reduced night or hypoplastic. The SWI sequences, again, slightly distorted due to motion artifacts, but there are, you can appreciate areas of blooming in the bilateral thalami. So the question was, is this a sequelae of infection or demyelination, or what does one need to think of progressive disorders such as leukodystrophies? I think the common question was, is it a possibility of a vanishing white matter disorder? But in vanishing white matter, the thalami and the deep gray nuclei are relatively are spared or not involved. The other possibility was mitochondrial leukodystrophy. Again, I don't think I have come across a case of hemorrhagic thalamus or thalamus with mineralization in mitochondrial disorder. So I think probably sequelae of demyelination infective etiology rather than a progressive leukodystrophy. And at this point, I'll open the case for further discussion.
I have no absolute suggestion. My gut feeling would be favoring an acquired condition, but of course I'm not sure. I mean, as I said, the initial MR was ONIC-like. Can you show that again? Okay, here.
Should one think of RAN-BP2 mutation? Should one do that? Whether
yeah, I think if there is a positive family history and
you might not have a positive family history, it's just the child who might.
Do they present with a single episode, or do they have recurrent encephalopathies, the RAN-BP2?
We might have it in future. This might be the first of more.
Okay.
Like these children, like when we had the dengue wave, no, in 2019, we saw a few children like where we gave early immunomodulation. We gave IVIG and steroids. Many of them have improved with that, but we gave it very early on. As soon as we saw the features, we gave it. And though they had a bad MRI, they did quite well.
Okay, I'll pass on the information to Preeti, since we don't have her here. So likely think of post-acquired sequelae, but also to test for RAMBP2 mutation. All right, thank you. The next set of cases are from Dr. Vivek. So Dr. Vivek, you can take over.
Okay, so this child didn't have much history. So he's a 14-year-old boy who had 2 episodes of easily controlled focal convulsive seizures, and he was well, and he's not had seizures since, and he's normal otherwise. And then he had an MRI brain, which we will see, and he has had multiple MRIs since, and the lesions have been stable. So Nihaal, do you want to go through?
Yeah. So here the MRI, I think. At what age was this done, Dr. Vivek? Is this a recent one or is it one?
So this one was the last one. So around 14-year age. In last 1 year only, all the MRIs, everything last 8 months.
So, okay. So you have non-contrast FLAIR images. You can appreciate that the cortex and subcortical region demonstrate this hyperintense foci in the right posterior frontal region. It will demonstrate corresponding area of restricted diffusion, no mineralization or calcification or foci of blooming on the SWI images. Post contrast, there is a moderate degree enhancement. And these are the only set of images I have. We don't have spectroscopy or perfusion. But you say that the changes, I mean, the lesion is same over the last 12 months. Is that right, Dr. A?
Yeah, it's been same. No change.
Okay. So I didn't have any slides for discussion, but I would think of low-grade astrocytoma or a glandular tumor as you have mentioned in the possible differentials. Possible calcification amount could have probably narrowed down the diagnosis to a embryonal or a granular tumor, but since the tumor is slow growing or not growing at all, I would think of a low-grade astrocytoma first than a glandular tumor.
Because there were a few things odd for glandular tumor. Do you see diffusion restriction in them?
No, yeah, not commonly.
Right.
What about
and
tuberculoma and neurocysticercosis, all of this?
But it's the same over the last 12 months, so I would have thought they would have regressed or some changes would have appeared over the serial images.
Okay.
Because a single scan, I would have thought of infective or inflammatory etiology.
The dilemma we have, it's exactly on the hand knob area. So to remove it with, so if it's a low-grade astrocytoma, so ideally one should take it out and have a look, or should one just keep doing 6 monthly MRIs? So that's the dilemma.
I think 6 monthly or at least annual MRI for the first 3 years would be helpful. Probably get a spectroscopy done for the next scan.
Right, because sometimes they just grow suddenly in between those 6 months.
Yeah.
So medico-legally, it becomes a problem. But we have not done anything for it. That's the thing.
What are the imaging differences between a low-grade glioma and a DNET?
DNET will have a more cystic appearance. It will probably resemble that of CSF on the FLAIR images, and T2 will be hyperintense. And it is more in the cortex than the subcortical region, more a bubbly type of appearance. Rather than here, it is more of a uniform hyperintensity.
And you would say there is some contrast enhancement, right?
Yeah. Contrast can be there also on DNET.
Yeah, and the diffusion restriction, that is the thing which is more in favor of astrocytoma, right?
Yeah. So maybe we'll get a follow-up in 6 months and then an annual follow-up later on for the next 3 years.
Yeah, sure. When I have get it done with my center MRI with MRS, then we can follow it up.
Sure.
Just discuss with the surgeons as well what is their viewpoint and document that and explain the family the risk of deficits with a biopsy or lesionectomy.
Yeah, so we had this 3-monthly meeting with Nilesh from Pune, epilepsy surgery. So we saw him there, and they also wanted to wait.
Documented that both the surgeons also would say the same, and medically as well. So.
Yeah. Thanks.
All right, thank you. Next case, Dr. Vivek.
So this is again, the MRI changes were incidental. So this is a 14-year-old boy who had short stature, and he had a tetralogy of Fallot, which was operated at 9-month age, and since then he has been growing well, except that he has had short stature, and he has subtle dysmorphism. He has dysmorphism, but his intellect is normal. And the MRI was done to look at the pituitary. So to look what could be the cause for his short stature, and not in the brain. And then incidentally they found something. So Nihaal, could we?
Yeah. Do you want to just any abnormalities here on the face?
So he's got a long elongated triangular face, small philtrum, long nose, slight retrognathia, ears turned back and slightly outside, and a prominent forehead, flat forehead, and slight maxillary prominence as well. But he's a normal child. He is extremely bright. He's very good in school. He's actually incidentally son of my classmate who is a pediatrician. So he requested his history and the MRI to be discussed in this meeting. So sure. I have seen him from early childhood. Yeah.
But according to the growth chart, he's not short. He's on the 3rd percentile, which is still in normal limits, isn't it?
But if you see over the years, for the weight, he hasn't gained much, but yes, height, he hasn't gained more than 4 centimeters in a year.
But if you look at the very first point, this is just a little bit above P3. So it also depends who takes the measurements and is it standardized?
Mm-hmm. P3. Like he is quite short visually. So, and his parents are not short. That like it's more than genes from his parents.
So actually they have calculated the mid-parental height in the chart. So he's falling below the mid-parental height.
Yeah, because he's there on the right side, they give the mid-parental height, which is somewhere right 25, and then he's much below that.
Okay. So move on to the images. So here is the incidentally detected lesion. We have the T2 weighted sequence on top, the axial images. And if you appreciate on the right parietal subcortical areas, you have these tiny areas of T2 hyperintensities. Again over here, slightly abutting the cortex. Posterior to the splenium of the corpus callosum, again these tiny T2 hyperintensities. And now the flare images, they do not suppress and demonstrate again flare hyperintense signal changes. Nothing on the SWI and nothing on the diffusion weighted sequences. This is post contrast sequences, again no enhancement of the abnormal foci. Just to evaluate the entire brain, no abnormalities in the rest of the supratentorial brain parenchyma and also in the posterior fossa. The pituitary gland non-contrast T1 weighted sequences, the maximum height was around 4.8 to 5 millimeters. I think for an age of 14 years, the normal height of the pituitary gland is about 6 to 8 millimeters. Post contrast, there is no microadenoma. The pituitary gland enhances uniformly. The stalk is also normal. Slightly hypoplastic or reduced pituitary gland, and these incidental changes in the right subcortical, parietal, and occipital white matter. I'll probably discuss the imaging first and get back to the case. So this is the diagnosis of the incidental lesions is likely a multinodular vacuolar neuronal tumor. This is actually a case taken from Twitter, posted by Ryan Peterson. And you can appreciate that the foci of abnormalities are similar to seen in our case. The differentials for these lesions are DNET, but on DNET and prominent virtual open spaces. But on DNET and the prominent VR spaces, on the FLAIR images, the type 2 hyperintense signals usually suppress and demonstrate FLAIR hypointensities. Focal cortical dysplasia, again, there should be a dysplastic cortex, and the signal changes are usually more iso-intense to the adjacent cortex. On the 2016 classification, the MVNT, this is from the 2016 book, but over here also they have mentioned that it is not clear whether the MVNT is a neoplastic process or a hematomatous malformative process. It was initially termed as MVNT of the cerebrum, but later on we had cases which also demonstrated these changes in the posterior fossa. So they have then changed the terminology in the 2021 classification to multinodular and vacuolating neuronal tumor. But based on the pathology, most of these cases are left alone. They are supposed to be left alone lesions, but on the pathology, again, if you see these the research reviews and case reports, it remains again a possibility of a developmental anomaly rather than a true neoplasm. So we're not certain if it is a neoplasm or if it is a malformative or a developmental anomaly. At this point, I think there was clinical suspicion of Noonan syndrome, Dr. Vivek.
Yeah, Noonan syndrome is a possibility. Yeah.
Okay. So these are again lesions associated with Noonan syndrome. From the literature, we have these multifocal hyperintense lesions involving the cortex and the subcortical white matter. They can also be associated with other tumors. This is because of they are involved in the RAS MAK pathway signaling abnormality, which results in increased oncogenesis. So Noonan syndrome cases can be associated with CNS tumors, but we're not sure if the case fits specifically or confirmatory with the Noonan syndrome. The radiological diagnosis of the incident finding is an MVNT and the pituitary gland is slightly hypoplastic for age. That's on the imaging. So now I'll open the case for further discussion.
Why can't it be simple hypoglycemic brain injury?
This is usually bilateral and it's more posteriorly.
Yeah.
And subcortical also, cortical subcortical. I would not consider that further. But it's I think it's a kind of incidentaloma, whatever you call it.
Yes.
It has nothing to do with his presentation and with his dysmorphism and stature. And it's Noonan is, as we have seen, is genetically heterogeneous. You need to go back to the genetic results.
So genetics, I will give the feedback when it comes through. It's just because father is a pediatrician and the report comes as a tumor, so it becomes worrying for the family. The tumor word, it's just the word tumor given to it.
Yeah, but if you see even in their official book of the 2016 classification, they have mentioned that it is not clear whether it's a neoplastic process or hematomatous or a malformative process. Because they are generally considered to be not to be touched, we usually don't get pathology for most of these lesions. So we're not sure if it's just a neoplastic process or something going on under, if it's a malformation or just a hematoma. But Nihaal, they can present with seizures later on.
Okay, no, that's very useful. Thank you.
Yes, Dr. Mankad, I think this case is of interest for you.
Yeah, no, sorry. First of all, I was late. I just wanted to know one step back as to why was the brain scanned? Because we don't always screen brains for Noonans, right? What was the reason? Were they dysmorphic?
Short stature for pituitary.
So for pituitary. No, I fully agree with your diagnosis. The question really is, how will you survey this? Are we subjecting this kid to surveillance imaging? Because that's what people have done with their MVNTs and not gone anywhere. But how long do you keep surveying for is a question as well with these. Could we just leave this as perivascular spaces and as a differential? Do we have to call this a tumor?
But they don't suppress on T2 flare, so it cannot be a perivascular space, right?
They don't always suppress on flare, the perivascular spaces as well. That at least the giant ones don't suppress. But even if you give a differential, whatever differential you give, I think the team here should decide on the strategy for surveillance, this is what we all struggle with as to how frequently should we be scanning, what should we be doing. Then there are those smart people who would try to put a spectrum on this and pick up some peaks. Question is, I think you should do as barely minimal as possible and maybe just do in a year's time and then keep doubling that interval basically.
Okay.
I agree, or to be provocative, this boy is victim of modern imaging technology, and I would try to keep it as low as possible. I would even question whether I would have surveillance in my relative. This looks very benign.
I totally agree. I think if anything, I would just do a flare sequence and leave it at that, frankly.
Yeah, maybe leave it, because since parents, doctors, pediatricians, something which looks so incidental, if we keep doing the flare, it will never go away. So we'll keep doing it, So maybe, Krish, if it's fine, then maybe leave it, and because there will be no end to it, because it will keep coming.
Yeah, the possibility of a glioneuronal tumor has been raised, and it has correctly been raised, to be honest. So I will do at least in 1 year's time, and then I can do it in 3 years or whatever, and then stop at some point. He will need at least one follow-up, and Nihaal will agree that, at the moment, we still don't know what the biology of this is, apart from labeling it loosely as a glioneuronal tumor, basically.
Yes.
So we are not labeling as a glioneural tumor, right? We are labeling as MVNT, it is a glioneural tumor, is it?
Yeah, it comes under the glioneural tumor.
It is.
Okay.
I have a provocative remark. If you call this a tumor, will he be able to have sportive activity? Will he be able to have a life insurance and so on? So you make some obstacles to him, I guess. Maybe I'm too naive to balance the situation, but I think we should try also not to do harm with diagnosis.
Very valid points, and I think that should be discussed with the WHO classifiers as well, as to what are these entities being created and then left quite open. But nobody has written a criticism piece for the WHO classification of brain tumors again.
Anyway, this was an interesting case. Thank you.
All right, thank you. Next case again, Dr. Vivek.
Yeah, so this one, again, the symptoms were not that much as what came out, like they were later on his MRI. So he came 2 months back, he had fever for a week, which resolved. And then over the next 2 months, he developed abdominal distension with intermittent abdominal pain, but fever didn't come back. And 15 days prior to admission with us, he had these multiple nodular lesions, more on the scalp, and rubbery, more like rubbery lymph nodes, more like you see in Hodgkin's, cervical, supraclavicular, even a Virchow node on the just above the left clavicle. And he had a large liver, around 7 centimeter below right costal margin, but no splenomegaly. He had a low hemoglobin with reticulocytosis, 6%. DCT was negative. His hemoglobin electrophoresis is negative. And blood film doesn't show any hemolysis. And LDH was just mildly raised. Ferritin was normal. His platelets and white cells were normal. So it was the anemia. It's 6.8, not 6 to 8. So 6.8 with the reticulocytosis. So that was his history, but nothing to the neurology as such. So he didn't have any CNS issues. He came more for his, so MRI brain was done more because he had nodular lesion on his scalp.
Okay. So moving on to the MR images, we have, the diffusion and the ADC sequences. Axial images, you can appreciate that there is confluent or extensive abnormalities involving the bilateral calvarium, extracalvarial region, demonstrating areas of restricted diffusion or low ADC signals. also extending into the brain parenchyma in the bilateral cerebral hemispheres. There's also some restricted diffusion in the area of the sphenoid, extending up to the optic pathway and the optic canals. T2 and T1 weighted images, you can better appreciate the extent of the lesions involving the calvarium, the extracalvarial region. I think these are the result of the external swellings. Again, diffuse abnormalities involving the calvarial region extending into the brain parenchyma. Some thickening of the optic nerve on the right side in comparison to the left. Sagittal images, again, you can better appreciate these bony abnormalities. On T1, they are isointense, slightly hyperintense. Foci are demonstrated in the left frontal region. Again, some infiltration in the sphenoid sinus and in the proximal optic pathway on the right. The SWI images, the lesions demonstrate heterogeneous appearance but predominant blooming on SWI. Post-contrast sequence, there is uniform enhancement. Some areas of non-enhancing foci in the frontal regions and in the areas of the large lesions which demonstrating necrosis. Again, the cavernous sinus or the sphenoid sinus demonstrates these areas of infiltration. There is some enhancement of the bilateral optic nerves. The CT images were given to review for enlarged lymph nodes, but I cannot appreciate any lymph nodes on these images. So the liver also, we don't have the complete image of the liver to see for hepatomegaly, but no paraspinal lesions, no mediastinal abnormalities. So based on the images, I would thought of differentials of neuroblastoma mets. I'm not sure if that was detected on the CT abdomen for any adrenal lesions. Other possibilities were leukemia, such as the granulocytic sarcomas, histiocytosis, the non-Langerhans cell histiocytosis can also demonstrate these type of lesions. And lastly, extramedullary hematopoiesis. But in the extramedullary hematopoiesis, the T2 lesions are usually hypointense, whereas in our case, there was slight hyperintensity, and they're not as aggressive as seen in our patients. So we'll probably put extramedullary at the last, but think of the other differentials. And at this moment, I'll open the case for further discussion.
Nihaal, both me and you are not chest radiologists, but I wondered about the coronal CT of the chest. That doesn't look normal to me.
Yeah, it's not normal. There is some.
It's quite a diffuse process of something going on there.
Some ground glass opacities are there on both lungs.
And the bronchiectatic changes, as well as, if we start looking at those as nodular changes or tree in bud kind of appearance, I think he might have a systemic involvement. What was the presentation again? Just a lump, I was told, right?
Yeah, just external lumps on the scalp and cervical, lymphadenopathy kind of changes. Yeah,
and the blood film shows nothing which is contributory by the looks of it.
So there were the one thing which I missed writing, the blood film had smudge cells. So smudge cells are suggestive of chronic lymphocytic leukemia.
Yeah.
But his bone marrow didn't show it.
So I think I agree with Nihaal. The primary differentials here are a hematogenous malignancy and neuroblastoma. I'm just wondering what's happening to the brain, because there's probably dural invasion, right, and edema within the brain, and those cortical folds appear a bit thickened, so there could be parenchymal invasion actually.
And is the GRE hypointense, Nihaal, in this?
It is blooming, but that is because it is involving the calvarium. So.
Plus, it could be hemorrhagic as well, right?
Yeah.
So blooming, suggestive of hematogenous. What did you say?
Hematogenous infiltration, and the bone usually is dark on GRE. So because it is a calvarial lesion.
Okay.
The only thing against
because of that.
Yeah. I think the concern raised was extramedullary hematopoiesis because the lesions are more hyperintense than what we usually see in extramedullary hematopoiesis, which is uniformly dark on T280 sequences. But here it is, as you can see, it is not dark. It is more of an hyperintense heterogeneous appearance, and the lesions are more aggressive.
And I'm concerned of mets in the lungs as well. I'm very concerned. I've not reported a CT chest for many years, but that lung doesn't look correct either. Vivek, did they have an ultrasound? Sorry?
Yeah, the CT abdomen was done. I think they would have picked up if there was something in the adrenal gland or something in the.
Yeah, the upper bit.
Yeah. Anything on that, Dr. Weird?
No, not on adrenal, but I do have just now message hot from the press, the excision biopsy result. Just had.
Okay.
So it's a undifferentiated round cell tumor from the biopsy report. So round cell tumor could be neuroblastoma, as you suggested, Wilms tumor. So some sort of a malignancy. Yeah. So the excision biopsy from one of the the scalp lesion, chest lesion, from the chest lesion.
Oh, so they have detected a chest lesion. All right.
Yeah.
Okay. Thanks for the instant feedback. They should do well. Have you done the spine? Because that's the other place where it compresses the spinal cord badly, without manifesting.
Yes. So not done the spine, but we'll do it. So that's sure.
Yeah. Right.
So yeah. So yeah. Yeah, that's fine. Thank you.
Okay. And this is our last case.
Fascinating
Lokesh,
images there.
Yeah. So last case, Dr. Lokesh, is the follow-up one. Do you have any present features of the case? This was a 3-year child with progressive vision loss, the confirmed abnormalities in the posterior cerebral hemispheres.
This is what's his name?
Rianshi Palepu.
Yeah. So unfortunately, we don't have any further genetic answers as of now. Whole exome and CMA and mitochondrial genome sequencing are all normal. Biopsy
The only
had
thing
shown.
is, he was scanned in September. Any reason to be rescanned again now recently? Because we have 2 scans.
So what happened is earlier he had only visual loss, and now last 15 days he started having motor decline and regressing rapidly. So that is when parents got the scan done and came to us. But the biopsy of the brain lesion, which was done in the initial part itself in the genetics, came negative both for adrenoleukodystrophy and other genes. Was showing only evidence of either possibility of Krabbe disease versus the presentation. This CNS lymphohistiocytosis. Yeah.
Okay, sure. So this is the scan. I think this was previously discussed in one of our meetings. This posterior predominant confined white matter abnormalities with restricted diffusion, also involving the splenium of the corpus callosum. So in the T2, you can appreciate the confluent abnormalities with the posterior predominance. Flare, there is no areas of cystic degeneration. It is uniform. It is hyperintense. Some areas of low signal changes in the spleen of the corpus callosum, but no foci cavitatory lesions or cystic changes. Slightly image, you can appreciate the involvement of the splenium. There was no mineralization or blooming on the SWS sequences then. Post contrast, only there were slight areas of linear areas of enhancement, not very significant. No peripheral enhancement as we typically seen in X-linked adrenoleukodystrophy. Spectroscopy was done. There was an elevated choline peak with a lactate peak and a reduced NA creatine peaks. So at that point, genetics was sent, which was negative. Antibodies, MOG and NMO was negative. GFAP was negative. Oligoclonal bands, I think, also was negative. CSF analysis was normal. And for the September scan, we thought of these possibilities. Then a biopsy was done. Biopsy gave a possibility of Krabbe's disease or a histiocytic disorder. Enzyme analysis for beta-galactocerebrosidase was done, and they demonstrated low enzyme activity. Is that a consideration for a possible Krabbe's disease, Dr. Lokesh?
heterozygous hit, I think the child had for Krabbe. We didn't have a homozygous hit, and sometimes you have a low levels of enzymes in the Krabbe is what they say. So unless you have we didn't find another hit for the Krabbe.
Okay. So coming to the most recent scans, this was done last week, and you can appreciate now on the T2-weighted sequences, there are areas of cavitations in the posterior parietal white matter. There's also progression of the white matter changes involving the mid and posterior frontal white matter. Areas of restricted diffusion also demonstrated in the peripheral aspects. Here again, you can appreciate the cystic or cavitating changes and the progressive white matter abnormalities. Coming down to the brainstem, there's also involvement of the pons and the ventral medulla. This you can appreciate on the sagittal images. Again, there's progression of the involvement of the corpus callosum. Again, nothing on the SWI sequences, but on the spectroscopy, again, we had a similar spectroscopy peak as seen in the September scan with an elevated choline and an elevated lactate. So at this point, I just tried to raise the question was, are we just dealing with Krabbe's, or should we consider mitochondrial leukodystrophies as a possibility, and do genetics pick them up? And what is the what is the yield of genetics for this kind of abnormality? And how do we follow up the case?
Mutations, generally the yield is good. Particular pattern of mitochondrial cytopathy.
So Lokesh, here adreno is out, isn't it? Because she's a female and is 3-year-old. So adrenoleukodystrophy is unlikely, right?
Child?
So
no, male child.
Male.
Oh, it's a male child, is it? So we did very long chain fatty acids.
Normal. First report we got was very long chain fatty acids, which were normal.
Right. So that was normal. So, and did we do a nerve conduction in her? Just for the phenotype of Krabbe's, just to, because we don't have genetic, but we do maybe MRI and enzyme analysis. So
Nerve conduction was normal.
Normal. Yeah. And would you think of SSP by any chance in this situation, a child who is regressing? Because
there is no cognitive.
Sometimes you do, cognitive regression. No cognitive regression. No.
Yeah. I'm not sure whether that would be explained by an SSP.
At what stage would you consider biopsy of the tissue itself? As such, it's cavitating away.
No,
biopsy was done.
In the initial period. This is the biopsy report. This was done in, I think, November somewhere.
I see.
So the biopsy gave it as possible Krabbe's and histiocytosis disorder.
You can do skin biopsy, right? They do it in Niman's. It's very simple procedure.
I would send a biopsy. I would send a histology for a second opinion somewhere if possible.
So Lokesh, you had a heterozygous mutation for Krabbe 1. Is that right? Or you didn't have anything for Krabbe in whole exome?
Single hit.
Sorry?
Mutation, not compound heterozygous.
No, your voice is breaking. So can you repeat it again? You didn't get anything.
Single heterozygous mutation for Krabbe.
So did you do microarray after that, like for a deletion duplication on the other gene?
Yeah. Microarray, mitochondrial genome sequencing, both of them are normal.
Okay. Right.
Another lab for analysis. We should get it sometime soon.
Just the question.
What have you sent for analysis? What have you sent for analysis, Lokesh? And get the answer.
Data, genetic data.
Genetic data.
Yeah,
okay.
genetic. Yeah.
Yeah, just the question was cavitatory changes in Krabbe's. I haven't found any missing, but in the literature.
Oh, but the
Dr.
end
Pankaj, any
stage,
experience?
but the end stage of any
Okay.
of this can be cavitating,
Yeah,
right?
yeah.
That's not a surprise.
Okay.
I think actually end stage Krabbe's, which I have had, I'm sure Eugen has also seen, is almost like, you know, the devastating effects of hypoxic ischemic injury. It could be quite global as well. Show us the thalami a little more closely, if you have any cuts through it.
No. Okay. Yeah.
That's fine. It is quite localized, but I think cavitation doesn't take us away from end stage Krabbe's.
And Nihaal, do you see diffusion restriction in a storage disorder? Because there was some, isn't it, in the splenium storage diffusion restriction? Do you see that in a large molecule storage disorder?
We do. The
Sorry.
MLD and we do the MLD and Krabbe's do show vesicle diffusion.
Okay. Okay.
So if you have one mutation and slightly low activity on the biopsy, isn't that enough?
What is it is if you have heterozygous mutation, that can sometimes give rise to low enzyme levels.
I see.
Quoting that.
And what you're calling cavitation is also calcified, right? I think there is some.
No.
Is there calcification as well out there?
This is SWI.
Second picture, lower panel. What is that dark bit?
This one?
Yeah, and below that.
So this is the flare.
Dark.
So this is what I'm calling as cavitation or cystic degeneration. So this is the SWI image.
Okay. Not the typical cavitation, right? As in mitochondria.
Yeah. Mitochondrial more diffuse, more patchy involvement. Okay. There are no further comments. We'll probably evaluate for Krabbe's and get back to you.
Yeah. Sure. Okay.
Okay. Right. That was the last case. So thanks once again, everyone, for joining in. Thanks again. Thanks, Dr. Pankaj, and rest of the panelists for your discussion.
Thank you very much, Dr. Nihaal. Bye, everyone.